What we're presenting in this conference, among other things, is a sub-study of the Catalyst collaboration of trials that investigated the optimal timing of anticoagulation after an atrial fibrillation-associated ischemic stroke. There have been 4 randomized trials on this issue that have been completed and have been meta-analyzed, their individual patient data, that is, in the context of this Catalyst collaboration. What the main meta-analysis of Catalyst showed, that was published some time ago, what it showed is that when starting early, that is within 4 days, as opposed to later, that is at day 5 or later, you reduce the risk of recurrent stroke. That's including ischemic stroke or intracerebral hemorrhage or undifferentiated stroke. So a question that we were interested in is whether there is still net benefit coming out of this approach, out of starting early, considering the fact that when you examine all of these outcomes together, you're implying that they're equivalent in their clinical importance. But we actually do know that an ischemic stroke is not the same as an ICH, as an intracerebral hemorrhage. So that's what we wanted to do with this meta-analysis of Catalyst, investigate whether there is also net benefit coming out of the early treatment approach besides just reducing the number of events. We investigated this using established methodology, and what we found is that after you wait events for, say, the potentially more severe impact that an intracerebral hemorrhage may have compared to ischemic stroke, you still find that early treatment is associated with a net clinical benefit, a positive effect, about 1 weighted event prevented per 100 participants. Although with large uncertainty around this point estimates. That was in a population of 5,500 patients from the Catalyst meta-analysis, and it still supports, or it further supports, I should say, the findings of the main meta-analysis that early treatment seems to be beneficial. Another thing, and a sub-analysis that we did within this context of looking at the net clinical benefit, is we also examined what the actual severity and disability coming out of these events that happen either with early or with later treatment is in the context of Catalyst. There was a total of about 120 recurrent strokes, either ischemic or hemorrhagic, that these patients had in Catalyst, 50 with early, 70 with later treatment. And when you compare the subsequent disability, so that was 50 and 70 events in the first month, in the first 30 days, and then you look at the disability at 90 days. So when you compare the subsequent disability coming out of these events, this does not differ between the early and the later approach. So no evidence that starting early leads to more disabling strokes, coupled with the fact that we find a net benefit when we do this calculation, coupled with the fact that early treatment reduces the actual number of strokes, everything speaks in favor of starting early.